The Global Surgery Lab presents an approach to bowel resection with hand-sewn anastomosis. The goals of this video are to 1. Identify indications, 2. Demonstrate a step-by-step approach, and 3. Outline key principles of post-operative management. Indications for bowel resection include perforation, ischemia, trauma, tumor, stricture, obstruction, inflammatory disease, fistulas, and congenital anomalies. Contraindications include widespread metastatic disease, and risks of the procedure include intraoperative contamination of the abdomen, postoperative anastomotic leakage, intraoperative injury to other organs, bowel obstruction, GI motility complications, and other complications common to all surgical procedures. The general outline to this approach includes 1. Make a vertical midline incision, 2. Isolate the bowel to be resected, 3. Resect the affected segment with its mesentery, 4. Hand sew the anastomosis and close the mesentery, and 5. Ensure hemostasis of tissues as well as patency and integrity of the anastomosis. Close the incision and follow up with post-operative care. You will need a needle driver, scalpel, sutures, forceps, toothed and non-toothed, retractors, Metzenbaum scissors, electrocautery, and non-crushing clamps if available. Alternatively, the strings can be cut from laparotomy pads and used as ties if non-crushing clamps are not available. To begin, make a vertical midline incision and explore the abdomen to identify the area for resection. This area should minimize margins in order to preserve as much length of viable bowel as possible. Isolate the operative field as best you can by adding extra sterile towels to avoid contamination of the abdominal cavity with spillage. Note that although not demonstrated in this video, to prevent spillage of enteric contents, non-crushing clamps or ties, as shown here, can be placed on either side of the section of bowel planned for resection. Note that care must be taken not to damage the healthy bowel. To begin the resection, use the cautery proceeding obliquely to ensure that the remaining free edges after resection will have a blood supply. Create windows in the mesentery of the bowel to be resected. Divide the mesentery, ligating the arteries and veins with ties. Next, transect the bowel using the cautery. This should be done obliquely, again to maintain blood supply to the anti-mesenteric edge. Next is the anastomosis. Here we are using the hand-sewn end-to-end technique. Place a suture through the mesenteric borders of both bowel ends and tie a knot. Place stay sutures through the anti-mesenteric borders of both bowel ends. Then, run each suture towards the anti-mesenteric border with one anastomosis on each side. Tie the sutures when they meet at the anti-mesenteric border. Close the mesentery with a running suture, taking care not to injure the vessels of the mesentery. Finally, confirm patency and integrity of the anastomosis. Irrigate the abdomen with warm saline, then close the fascia with a running stitch, and finally, close the midline incision using interrupted, horizontal mattress, or vertical mattress sutures. Post-operatively, keep an eye out for early signs of infection. If there is evidence of an ileus or bowel obstruction, a nasogastric tube should be considered. A good surgical outcome results in return of normal bowel function. In conclusion, a bowel resection and hand-sewn anastomosis can be done to remove sections of bowel.